So on behalf of Cure Glaucoma Foundation, thank all of you for being here, and please welcome Dr. Butler.
Well, thank you, Mike, and thank everyone for coming out. It's really nice to see people, and welcome to the people on Zoom as well. I see a lot of familiar faces, but for those who I don't know, I'm Michelle Butler. I'm one of the doctors at Glaucoma Associates of Texas. I'm also a board member of the Cure Glaucoma Foundation. And really, this is for you. We want this to be an educational opportunity, a chance for you to ask questions. I do have some slides prepared. We'll run through those, but please, if you have questions, that's what I'm here for. This is what I intend to cover today. Just going to give you a little introduction first about who I am, and then a little bit about what glaucoma is, just so we can all be on the same page and have a discussion. The bulk of what I wanted to focus on is kind of living with glaucoma. What does that mean? What are the implications? What are the expectations? What can you do? What should you avoid? That's where I get a lot of those questions when I'm seeing patients, and so I wanted to kind of focus on that today, but I'm happy to take questions about anything relating to glaucoma. I just ask that questions about your personal treatment really should be in a private situation between you and your doctor, but if there are general questions, I'm happy to answer those. The Cure Glaucoma Foundation, just as a brief introduction if you're not familiar with it, it was started in 2014 by the doctors at Glaucoma Associates, and it's really expanded. We have a focus, kind of three different pillars of the Cure Glaucoma Foundation, focusing on local access to care, funding basic science and clinical research, and then expanding a global outreach, really to make sure that we are taking care of glaucoma all over the world. This is my work family. So these are the doctors of Glaucoma Associates of Texas. Y'all probably know one or many of them. From left to right, it's Dr. Tosin Smith, David Godfrey, Devendra Grover, Ron Fellman, Helen Kornman, myself, Michelle Butler, Matt Emanuel, and our newest addition, Shivani Kamat. I've been with Glaucoma Associates for about 8 years now, and it's really a very unique practice for those who aren't kind of into the medical field or familiar. It's very unusual to have a private practice glaucoma subspecialty practice like this. You don't find this really any other place in the country. So it allows us to do very unique things, to be able to see such a range of glaucoma and really push the field forward. A little bit about my background. I grew up in Lake Jackson. It's a really small town on the Gulf Coast of Texas. I went to A&M for my undergraduate, then came back to Houston, to Baylor College of Medicine for medical school and stayed there for residency. Briefly left Texas. I went to Miami for a year to do a glaucoma fellowship at Bascom Palmer and quickly came back to Texas, where I've been at Glaucoma Associates ever since. And this, just so you kind of get to know me, this is my home family. That's my husband, Craig. We met 19 years ago at the A&M UT football game, and you can tell he is wearing his Longhorn tie tack. So we are a house divided. These are my two sons. I have Nathan is 9, Colin is 6. This is like the 30 seconds where they weren't wrestling with each other. Very active, loving, love my boys. And that's my geriatric dog. He's Chester. He is 15. He'll be 16 in a couple of months. He's been with us. We rescued him when he was 1 year old, so he's been with us and part of the family. Okay, so let's jump to glaucoma. Just to kind of get the basics out of the way. Glaucoma, it's kind of hard to define. If you look in a lot of our medical textbooks, there's like a whole paragraph on what is glaucoma. But in general, it is a group of eye conditions in which there's damage to the optic nerve leading to progressive irreversible vision loss. So we're looking at, this is the optic nerve. On average, it's about 1.7 to 1.8 millimeters and has about 1 million axons. Those are the wires that connect the nerve, the eye, to the brain. That's how the signal gets back to the brain. So when this nerve starts to deteriorate or thin, that's what glaucoma is. That's what causes the vision loss, and that's what we're trying to prevent. When the doctor's looking at the back of your eye, we are looking at a cross-section of that cable, of that optic nerve. On the left, I have normal. This is what we call the disc. That is those wires. And you kind of think of this like the donut. If you have a donut, you have a hole in the middle. That hole is where the blood vessels come out. And we're looking at the ratio of that hole to that whole disc. In an eye without glaucoma, usually that hole is less than half of the diameter of the whole disc. But if you have thinning or atrophy or deterioration of those wires, that hole gets bigger and bigger. And you can see in glaucoma, you have a much larger opening. And that's one of the clues that says we need to be looking for glaucoma. There are different types. Glaucoma is really an umbrella term. A lot of different things can result in that deterioration of the optic nerve. You'll probably know that it's divided into a couple different categories. You may have heard open angle and closed angle. A lot of people ask me, what type of glaucoma do I have? The reason that's important is because it's actually managed differently. There's some different treatments that we do if it's open or closed. And I'll show you a slide on what that means, what is open and what is closed. But beyond that, we actually divide it a step further. There can be secondary causes. That means there is some other condition, either in the eye or systemically, that results in glaucoma. Or primary, meaning there's nothing else that's causing it. It is just glaucoma. So this is the open angle, closed angle. A lot going on this slide. I'll kind of walk you through it. Your eye is always making fluid and draining fluid. This is different than the tears. I'm talking about inside the eye. The fluid is made in this part of the eye. It's behind the iris, so behind the colored part of the eye, and this process is called the ciliary processes. It travels around the lens through the pupil. So the pupil is an empty spot, empty space. It comes into this front part of the eye. We call this the anterior chamber, just space in the front part of the eye. And then it has access to this drain. This is actually a tube. It goes 360 degrees around the eye. That fluid is able to get into that tube, into that canal, and get back into the body. That's how it's supposed to work. This angle, when we're talking about the angle, it's where the cornea, the clear dome of the eye, meets the iris, the colored part of the eye. In an open angle, that's usually around 30 to 45 degrees. If the eye may be smaller, you still have all these same structures, or maybe that lens is bigger, things start to push forward. And all of a sudden, that fluid has a hard time. There's not much space to get to the drain. That's narrow angle. And we treat these a little differently. They both involve pressure, but with this, we'll recommend a laser. And I know I had some questions from online, I think, already submitted about should you do a laser for narrow angle? And the answer is absolutely. What that laser does, we recommend we do a laser right here in the colored part of the eye, in the iris, and we can do that here in the office. That allows that fluid that's made here to have a way to get to that drain so it does not close up completely. If this closes up completely, that pressure goes up super high really quickly, and it's very dramatic, painful. Oftentimes people go to the emergency room. So that laser prevents you from having an attack of glaucoma in this narrow angle form. That's not necessary in the open angle form because that's not the problem. So we divide it into these different classifications because we treat it differently. Now, everyone knows pressure glaucoma. Yes, that's true, but I've talked this much and I'm just now starting to mention eye pressure. So pressure is important, but it's not the whole story with glaucoma, right? Glaucoma is that change in the optic nerve. It is a big risk factor. We know high pressure is a risk factor for developing glaucoma. So normal eye pressure is usually between 8 and 20 for most people. There are some people who have pressures that are 25, that are over that normal range. They do not have glaucoma, meaning they have healthy optic nerves. That's something called ocular hypertension. Then there are people, about a third of all glaucoma, who never have pressures over 22, and they have glaucoma. That's normal tension or low tension glaucoma. So they have those optic nerve changes. Regardless, we know once you have glaucoma, lowering your pressure from your baseline can slow down or stop the progression of the disease. So it is important, but it's not the whole story. And we have various ways of checking eye pressure. It is important. We always check it when you come to see the eye doctor. Often with us, we use that blue light. I love this cartoon. Unbeknownst to Dr. Thornton, the air puff test was set to hurricane blast. I think it feels like that sometimes. Okay, so how do we diagnose glaucoma? I just kind of told you what glaucoma is. How do we actually know if you have it or not? One of the other questions I got was, what are the signs? How do I know if I have glaucoma? It's tricky because there really are no signs. There's nothing that you would notice at home. You don't notice the vision changes. You don't feel your eye pressure. So a lot of times it's found just incidentally on, you go into the eye doctor because you need some update on your glasses or you're not reading as well. And they either find a high pressure or they look at your nerve and see something suspicious. It would be nice if there was something that would bring people in, but there's not, so there's not a great screening to it. You really need a good eye exam. It is the leading cause of irreversible blindness worldwide. Cataracts are the leading cause, but that's reversible. You can do cataract surgery and fix that. We can't fix glaucoma, so we want to catch it as early as we can. It's estimated that worldwide about 60 million people have glaucoma. Like I said, you really need a good eye exam. That's how we diagnose glaucoma. It has to include checking your pressure, looking at that drain. That's when we put that lens on your eye, and it looks at the drainage structures. We're looking to see if the drain is open or if it's closed. And a dilated exam, we really want to get a good three-dimensional view of that optic nerve. I showed you some pictures here, but actually with the microscope that we use, we see a three-dimensional view of the optic nerve. We can see how that opening cups back, and it gives us a good indication what the risk of glaucoma is. If it's suspicious enough, then we start to do some of those other tests. That's when we get the visual field and the optic nerve scan looking at the structure and the function of the optic nerve. And we're going to show you that here in just a second. So the visual field is the functional test. It measures your peripheral vision. Again, on the left, I have the normal. This is a normal blind spot. That's where your optic nerve enters into your eye. You have a physiologic or normal blind spot. So this is a normal visual field test. This is the test that everyone loves. Press the button when you can see the flashing light. This one is glaucoma. I'm sorry, my A got moved over. With glaucoma, you typically start to get usually some areas where you need a brighter light either towards the nose side or in this arcuate fashion, above or below. And then this is the structural test that we often do. This is what we call the OCT. This is measuring the thickness of the optic nerve. Again, normal is here. I'm not going to walk through all this, just going to show you right eye, left eye. This measures in microns. The technology is amazing. In microns, we're able to measure the thickness of the optic nerve, compare the right to the left, and compare over time to tell if it's changing or not. So that brings us to, we've made a diagnosis of glaucoma. Now what? What does that mean? What do we do? The goal is to lower your eye pressure, to slow down or stop it from getting worse. And I got a lot of questions on this one. Can we improve the vision? Can the optic nerve regenerate, regrow? We do not have that ability yet, but that is where the field is heading. That's where the research is at. Just recently, in fact, this year, there was a study that came out. It was a collaboration with some researchers at Harvard that they were able to take a stem cell. So a stem cell can differentiate into any type of cell. They were able to control it to differentiate into retinal ganglion cells, which is what goes on to make up the optic nerve. Then they took those cells and were able to implant it in mice and got it to incorporate into their retina. That is incredible. It's in mice, it's not in humans yet, but to get that kind of is very complicated to get the molecular pathway to differentiate a stem cell into a retinal ganglion cell, then to get it to incorporate, make the right connections, because I told you there's 1 million axons. It's not just a straight wire though. They're making all sorts of different connections, and in fact, half of those axons, half of those wires from the optic nerve actually cross paths in your brain and go to the other side. There's so much crosstalk. So we have to be able to get all that right in order to make it functional. So, I think it's really exciting. That's where the research is heading. That's where I think we will have that. We're still probably 10, 20 years from prime time in humans, but it's coming. The technology is just exponential, so it's really exciting. So right now, what do we have? Our goal right now is to make sure you don't lose any more vision, okay? And we do that by lowering the pressure, and we have 3 main ways of doing that. We can do it with medications, and recently there's even been new medications that have come to market. And there's now a little pellet that you can inject into the eye, and it dissolves over the span of a few months to release that medication. They're looking at different delivery mechanisms to get medication to the eye. Laser. Laser has been around a while, but it is still a very good option. It sounds, when I say laser, I think people start to immediately recoil, but literally it is taking light energy and directing it towards the drainage channel of the eye. Your drain absorbs that energy and it stimulates it to remodel, and it works more efficiently. There was a great study came out just a few years ago. It was called the LIGHT trial. It was done in the UK. Amazingly well done study. Looked at patients with glaucoma, it's like mild glaucoma, who had laser or drops as the first line. Laser did just as well as drops, if not a little better in some cases. And actually, less patients needed glaucoma and cataract surgery with the laser. So it's a great option for patients if their glaucoma is amenable to it. Doesn't work forever. It usually lasts for a few years, but it could be repeated. It doesn't cause any scarring. I know I got some questions about the laser as a treatment for opening of glaucoma. So it's a great option. And surgery, there's been so many advances in surgery in the past few years. When we think about glaucoma surgery, usually you're either working with a natural drain, so that canal, that tube I was talking about, you can open it, you can stent it, you can open part of it, you can open the whole thing, or we can bypass it. We can give you a new drainage system. We can create another outflow for that fluid to escape the eye to get back into your body. And we have multiple ways of doing that. So we have a lot of options for treating the glaucoma. Oh, I'm going to go back. I did get a question about a specific surgery. It's called the Omni. I apologize, I don't remember who asked the question. But what it is, Omni is a device that you use to open up the drain, that canal, the natural drain. It's a procedure very similar to what we do at Glaucoma Associates. We mainly do what we call the GATT procedure. Some of y'all may be familiar with that one. It's where we use a suture to open up. The Omni is just you use a catheter, it dilates the drain and then opens it up. But it is a very viable option. I think someone was asking if Omni is a viable option. It is, and it's FDA approved. Fortunately, it's actually uncommon to go blind from glaucoma in the United States if the disease is caught early enough. We have so many different treatment options available. The goal is to work with your doctor to find a path that works for you. Everyone's eyes are different. What works for you may not work for the person next to you or behind you or in front of you. So we've got to find the right path for you. In the beginning, it is a lot of eye visits. We generally see you about every month till we get things kind of settled down, figured out what you need, which drops you need. And then once things are stable, usually it's every 3 to 6 months, and then testing once a year. What can you expect? So vision-wise, most people know glaucoma kind of affects the peripheral vision and can tunnel in. It really depends on what part of the optic nerve that's affected as to where those blind spots might be. It doesn't just affect the peripheral vision, though. We don't have great ways of checking some of these other qualities of vision, but I have really astute patients, and they tell me all the time, you know, my right eye, just things are a little dimmer, or it takes a while when I go from light to dark to adjust the transition, or I need brighter lights in order to see. The glare gets me. Certain lights I see better, or my vision fluctuates throughout the day. So there are other qualities of vision that we don't do great at measuring in the office that can be impacted by glaucoma. But there are some things and kind of ways that we can work around it. If it gets to the point where the vision has been significantly impacted, a low vision specialist may be able to help. They have all sorts of different devices that are out there to assist you. Anything from magnifiers, telescopes, closed circuit TVs. With technology these days, there's all sorts of things you can do with your phone and your computer. Driving, I did want to mention driving. Most people with mild glaucoma, moderate glaucoma, no problems. If it gets to be more severe, it may be worthwhile thinking about limiting the night driving. times when there's low contrast. It's really hard to see with glaucoma in low contrast situations, and we don't want you to be in a dangerous situation. Your doctor is not going to take away your driver's license, but it is important to have that discussion with them about safety and driving. There are things people ask me about tints in their glasses, and yes, if putting a tint in your glasses helps you with glare, it's a very reasonable thing to do. You can talk to your optometrist or about that. And then just some safety things. Being careful. If you don't have great depth perception or one eye's not good, falls become a risk. So having an awareness, making your home as safe as possible, knowing that you need assistance, because just because your vision is limited, having an awareness of it can be a huge benefit to try and prevent you from having an accident with falling, or labeling your medication so we don't have any medication errors. Things like that I think are important to think about to help yourself or family members who might have trouble with their vision. And now what can you do? We want to take control when we have something like glaucoma. We want to try and take control as best we can. Best thing you can do is go to your eye exams. See the doctor regularly. Like I said, there's nothing you're going to notice. You're not going to notice, you can't feel your pressure, kind of like blood pressure. Unless your eye pressure gets really high, you don't know it. So you need to go in for your regular exams and take your medications. That's the best things you can do. After that, I would encourage anyone, if they're struggling with their drops or whatever regimen that you're on, talk to your doctor if the drops are irritating. If the insurance is not covering them anymore, don't just stop taking them. Have that discussion, because I just told you we have so many options. We may be able to find something else that works better for you. There are certain types of glaucoma surgeries, specifically a trabeculectomy, a very common glaucoma surgery. If you've had something like that, we always recommend wearing goggles when you're swimming. And this is just a public announcement here. Wear your safety protection when you're doing any sort of work that you might get particles or chemicals in your eye. I can't stand it when I see people doing their yard work or anything without protection. A split second and you have a tragic accident with your eye. So easy thing to do, wear that eye protection. And finally, very, very important, if you have glaucoma, it runs in families. Talk to your family about it and encourage them to get an eye exam. If they need to go every year and get their eyes checked. The earlier you catch it, the better off you're going to be. So you'll be doing a big help to any family member by letting them know. All right, so that was kind of most of the science part of it. If there are any questions, feel free now, or this is more of the what can we do, other kind of lifestyle type things. I'm gonna keep going. If you have any questions, we'll have time at the end too to answer. Diet, absolutely eat a healthy, well-balanced diet, for sure. People have looked at a lot of different supplements for glaucoma. It's really been mixed results. There's no clear, definitive answer that anything makes a big difference with glaucoma or your eye pressure. Just scientifically, it makes sense that maybe like vitamin A, vitamin C, your carotenes may help, omega-3s. And then ginkgo has been suggested for maybe a neuroprotective effect. Again, the data really doesn't play out that it makes a big difference, but I tell patients it doesn't hurt, with the exception of ginkgo. If you're on that, you do need to talk to your primary care because it can interact with other medications. But it doesn't hurt if I have patients who want to take multivitamins or other supplements. It's not going to hurt your eyes. I just don't have the data to say that it's necessarily going to make a difference, and it doesn't replace medications, laser surgery as the treatments. Exercise and hobbies. Exercise, absolutely regular exercise is great for your body. It's great for your eyes. There are a few very specific scenarios that we know causes higher eye pressure. Even if you have glaucoma, that doesn't mean you can't do these. If your glaucoma is controlled, you're on drops, you're had surgery, whatever it is, if it's controlled, I want you to live your best life. And if that includes doing these activities, that's fine. If we get to the point where things are getting worse, they're progressing, we're having a hard time controlling it, that might be a time that we reevaluate some of these. And that includes things like that would have your head down below your heart. So things like yoga, where you're inverted for periods of time, or those back inversion tables where you're laying reclined. That blood is pooling towards your head, pooling in your eyes, your eye pressure is going to be a little bit higher. Extreme weightlifting, that is not the normal go to the gym and lift. That is like bodybuilders, like lifting hard all the time. For the 99.9% of us, that is not an issue. And wind instruments that you have to play forcefully, we do know that bearing down does increase your eye pressure. But again, if the glaucoma is controlled and stable, I have no problem with patients doing those hobbies. We don't know a whole lot about what happens to your eye during sleep. Hard to check the eye pressure while you're sleeping, but just laying flat does increase your eye pressure. A study, it was interesting, and just because it's an association, you have to be careful. It doesn't mean causation. So this study found that too much sleep, which was over 10 hours in their study, or too little sleep, which was less than 3 hours, was associated with worse glaucoma. Again, that doesn't mean it caused it. There was just an association there in that study. And the more I go through life, I just feel like moderation is the key to everything, sleep included, I guess. I did want to mention sleep apnea. That is a specific disease that we've really become more aware of recently. It's where you stop breathing for periods of time at night. You're not oxygenating well, and the organs are not getting the oxygen they want, including your eye. That can cause changes that look like glaucoma. So if sleep apnea is a possibility, we always encourage getting a sleep study and getting it treated. This is a very common question I get. Cannabis. Can I use marijuana or cannabis because I have glaucoma? Let me tell you why we don't recommend it. It does lower your eye pressure, but it's very transient, okay? So it lowers it for a few hours, but you would have to take so much THC so many times a day to sustain that. It's just not practical. That would affect your mood, your clarity, your lung health. So it's not a practical treatment. It's not going to replace the medications, the laser, the surgeries that we have. And I told you I went to Miami for my fellowship. They actually participated in a THC eye drop study. So pretty popular in Miami. Unfortunately, it didn't lower the eye pressure and actually caused a lot of eye irritation. The eyes were very red and irritated, so that didn't go anywhere. There's been some talk about CBD, and so far the data hasn't shown that it has any benefit. In fact, one study actually showed that the pressure increased. So at this point in time, CBD is not indicated for glaucoma treatment. Caffeine, my coffee is my simple pleasure. Every morning I gotta have my caffeine. And I think it's fine for glaucoma patients to have some caffeine. It does increase the amount of fluid your eye makes, which can increase the eye pressure slightly. But all the studies, when you looked at the studies with the caffeine consumption and the glaucoma, it really didn't bear out that there was any relationship there. So what I tell the patients is it's okay to drink coffee or caffeine, whatever your form, just reasonable, again, moderation. Don't drink a pot a day, but if you want to have a few cups of coffee a day, I don't see any problem with that. Blood pressure, diabetes, and weight, kind of lumped these all together. First, let's tackle blood pressure. Low blood pressure is actually one risk of glaucoma progression. It's often associated when we think of the normal or low tension glaucoma. So we want to make sure that patients, especially if they're on blood pressure medications, kind of when they're taking it, if they're taking it at night, people's blood pressure tends to dip at night. And some people are what we call the bigger dippers, and their blood pressure is going down. So even simple things like changing when you take your blood pressure medication may make a difference. It's hard to get your blood pressure up, but make sure we're not getting dehydrated. That can help. On the other side of it, high blood pressure or hypertension is a low risk. It's a risk factor for glaucoma, but it's not as significant as a lot of the other risk factors like your genetics, your eye pressure, your optic nerve. And same with diabetes. It's a slightly higher risk, but not as significant as some of the others. And really with body mass index, the BMI, we're using that as a surrogate for weight here. The studies really haven't shown that there was much of a relationship between the two. It's been very mixed. So people ask, should I lose weight to help my glaucoma? There's really no data saying that it makes a difference one way or the other. Okay, I do want to talk about steroids. Steroids are sneaky. They're in so many different things that we use. About 5% of the population is what we call a steroid responder. That means when they use steroids, their eye pressure goes up significantly. That is higher with patients that already have glaucoma. They are more likely to have a steroid response. Usually that's when we're giving them steroids to or around the eye, so eye drops or injections around the eye. But it can come in different forms, right? You can have steroid nose sprays, inhalers, creams or ointments, pills, injections for your back, all sorts of different things. And we don't always think about that and how it affects the eye. We get calls all the time. I have bronchitis, I need a Medrol dose pack, is this okay? Yes. It's fine to have a little steroid, short course, not a problem. If it's something that's going to be sustained, then usually we tell you we want to check your pressure. It takes a few weeks before you start to see that pressure go up, so we may say come in about 3 weeks, a month, let's check your pressure and see how you do with it. Most people are going to be fine, but if you are one of those people whose the pressure goes up with steroids, we'd want to know about it and catch it. And finally, I think this is my last side, stress. This is another question I get all the time. Like, we're all stressed. Does stress affect my eye pressure? And I mean, stress affects your whole body. So my answer, I don't know how it can't not affect your eyes. But the everyday stressors, your job, your family, the traffic, waiting in our office for an hour, taking a visual field, whatever it is, probably not going to have much of an impact on your pressure, okay? Maybe a point, not a big impact. It has just anecdotally, when people have really big stressors in their life, I mean, deep emotional things, tragedy, death of loved one, difficult divorce, whatever it is, big emotional stuff, that can sometimes have an effect, but it's temporary. So we're able to manage through that, and it usually comes back down. I did have a question that I got about, I think it was COVID or COVID vaccine and eye pressure. And again, no, we've seen now thousands of people that have been vaccinated and pressures have been good. I will say sometimes when people get sick or have a big health incident, sometimes we have a little bit harder time with their pressure, but again, it tends to be temporary and come back down. So I'm not sure whoever asked that if they had an issue with their eye pressure, but if it was something that was kind of related to a change like that, it usually is temporary and would resolve on its own. Oh, I did want to point out this. There's only one study that I was able to find looking up this. It's hard to separate out stress and how it affects the eye. This is a hard study to do. So what they did is they took healthy people, checked their eye pressure, then made them get up in front of an audience and talk and check their eye pressure then, and it went up 1 point. So yeah, all right, maybe has a little bit of an impact, but not a huge, not a huge deal. And this was also an interesting study. This is a really small study. It's not a big or well-designed study necessarily, but it was out of India. And it was looking at people who meditated versus people who did not and kind of how that impacted the eye pressure. And in general, the people who were meditating did have a slightly lower eye pressure. Again, not a huge study, but I think meditation has a lot of benefits, and it certainly won't hurt the glaucoma. And that's all I have prepared for you. So I really want to take this time now to open it up to you guys and hear your questions and start the discussion. Yes, and I'm sorry, there's a microphone here. If you wouldn't mind, we can hand you the microphone, but that way the people on Zoom can hear. Yeah.
Hi.
Hi.
My name is Reli Katavi, and I'm from Israel. And I hear that, I'm sorry if my English is not, and
You're good, you're good.
so I hear that the drop causing cancer.
Drops cause cancer.
Cancer in the body.
No.
Okay. I lost my brother, 7 years old, 2 years ago, and when we was sitting there, his doctor came in, and it was in Israel, and I asked him, and he was like, is somebody else in your family have glaucoma? We all raised the hand, and he say, be careful with those drops because it's cause cancer. And I asked him why. He told me because the drops going to the cell and they changing the cell, and this is one. Second, I saw some study in Hebrew in YouTube with the professor. They was sitting there and asking question, and the professor says like this: the drop affect the body, but let's leave that in the side. We're not going to talk about it. So I'm asking you if...
I see where you're going. So drops do not get in the cells and modify the cells to cause cancer. They cannot do that. They do not do that. Drops do cause side effects.
Like what?
Depends on the drop. So we have a bunch of different drops for glaucoma. They all work to lower pressure, but they do it in different ways. And because there's different pathways that they are working on, they have different side effects. So let's just take a couple for instance. The most common thing we usually start with is what we call a prostaglandin analog. That's one of those ones in the teal top. Those typically cause side effects that are just confined to the eye. So they cause the eye to look a little bit red. They'll dilate the blood vessels. They will cause the eyelashes to get a little bit thicker, longer. Yeah, you get these beautiful lashes. They can cause some color changes on the iris, the colored part of the eye. People usually don't notice that unless they have there's some people that have kind of more of the hazel eyes where it's mixed color. Gets a little bit more of the darker color over time. If you're using it in both eyes, that's not noticeable. It's only when you just do it in one eye that becomes a little bit more noticeable. And then can cause a little bit of increased pigmentation of the eyelids. That's actually reversible and usually rarely an issue with this drop. So there are going to be side effects to drops. That's true for any medication that you take, though. Pretty much any medication you take, it's very rare that you have something that targets one thing and it does not have any other effects. But it's not going to get into your cells. It's not changing your cells. It's not changing your DNA. It's not causing cancer. The other drop I'll mention just for side effects is another common one we use. It's a beta blocker. Timolol, it's use it by yourself, and we use it in combination with a lot of different medications. That one can have some lung and heart side effects, where if it can lower your pulse. So we always are cautious. People that have a lower heart rate, we try and avoid that one. People that have underlying breathing issues, we're cautious with the beta blocker because it can make it a little bit more challenging to breathe. So I think it's very important we're treating the eye, but we got to treat the person, your body. And that's why some people are going to do better with one drop. Others are going to do better with a different drop. Others may not do great with drops at all. They may be much better off doing laser or even some of the surgical options. There's such an array of the surgery these days. It's not everyone gets a big trabeculectomy. We have a lot of other options in between. And we have to tailor the treatment to each person. And that's why it's kind of about finding your path and then kind of going on that journey with your doctor, because it may change as you go through life. We may have to adjust things. But there are a lot of options there. And I don't think that worrying about you're harming your body with the drops, that's not the case. Yeah, good question. Thank you for that.
One more question. Sure. I hear about the new generation of the medicine, the drop. Mm-hmm. What is this?
So there's been a couple of new drops that have come out within the past few years. One of them is called Vyzulta. It's similar to what we were using with our Lumigan and Xylatan. It has an extra molecule on it that lowers the pressure in a different way, so it's a little bit more impactful. The other medication is actually a completely different class of medications. That's your Ropressa or Rocklatan, y'all may have heard of. and it works completely differently, a totally novel pathway. So we can use that in conjunction with some of the other drops. So if we can target different points along this pathway to either decrease the amount of fluid the eye is producing or improve the outflow, that's what these are all targeting in different points. We can use them adjunctively together to get the pressure that we need. Yeah.
What time in the day, over the
Yeah.
day, you recommend to put the drop? Or in the morning, in the night?
Depends on the drop. So some of the drops we typically dose in the evening before bed. That's just customary because that's how the studies were done. Usually that's due because they cause a little bit of redness, and so they like you to sleep through that, and then it's not so bad in the morning. Other drops, the pharmacology of them, they're not 24-hour drops. They only last 8 to 12 hours, so we have to dose them twice a day and sometimes 3 times a day, depending on the drop. There's an old medication called pilocarpine that we even dosed 4 times a day. Now that gets to be difficult when you're doing anything, more than once or twice a day. To even just the 3 times a day, that midday is really tough to get in, and we recognize that. You're out doing life, so it's hard to get those drops in. But depends on the drops, depends on the pharmacology as to when we're going to dose them.
Thank
Yeah,
you.
you're welcome. Thank you. Yes, yeah.
Thank you.
Because glaucoma is a silent disease, symptomless, I'm wondering if at the national level there's been any effort to have a public service announcement, a campaign to inform people, because people, as you say, are not aware that they may have glaucoma.
Yeah, great point, and clearly we need to do better. There is a Glaucoma Awareness Month. There's a national organization, the American Glaucoma Society, that we're all part of, that we're trying to work to spread the word. But yeah, you're right. I think we do need to do a better job about getting the word out there. And it would be nice if we had an easy screen that we could say, hey, just go here, check this, or take a picture of your eye on your phone, whatever it was, and know if you have glaucoma or not. But it's hard because you need a full eye exam. Even I've tried to do lots of different health fairs and things, trying to go out into the community to screen. And it's hard because you don't have all your equipment there and you're not really sure, so then you're stuck telling, well, I don't know if you have something or not. So it would be nice once we have that. I think eventually we'll hopefully have something, but you're right. We need to get better about getting the word out there to get people into the eye doctor, get them checked. And I think part of it is making sure if someone in your family has glaucoma, they are telling people, and that gets them in. When you have your mom telling you, you gotta go get your eyes checked, or your wife drags you in, then they do it.
Well, that's why I was thinking
Yeah.
there are other diseases that have
Yeah.
public service announcements. And that's why I was thinking
Yeah.
if something like that, if you have a family member that has glaucoma, a
Yeah.
history in the family, certain things just the general public might look for and think, well,
Right.
maybe I need to get an eye exam, or maybe it's been a few years since I've had one.
Yeah.
But anyway, that just is something
Yeah,
I thought might help.
It would be great if we had kind of a national, someone with a national presence who maybe had glaucoma who could
That's
get the word out there. Absolutely. Yeah, great ideas.
Thank you.
Thank you.
Can I ask a few of the questions
Oh,
that
please.
were previously submitted?
Yes.
Okay. One is, if someone has glaucoma in one eye, what's the likelihood of that happening in the healthy eye?
Okay. So it depends on the type of glaucoma that we're talking about. I think one of my earlier slides I showed you, glaucoma is really an umbrella of all sorts of different conditions resulting in optic nerve damage. So if we're talking about one of those secondary glaucomas, there's a reason that you had that in that eye, and it may be that you had an infection. Maybe you had corneal surgery or retinal surgery, or maybe you had trauma or an injury to that eye. There may be a reason that you just have glaucoma in the one eye. In that case, that doesn't mean that the other eye is destined to get it. If we're talking about primary glaucoma, that is typically bilateral, meaning both eyes would be affected. It can be very asymmetric, though. one eye could be affected while the other one's not yet, though typically over time would become effective. So we usually go ahead and treat both eyes frequently, or watch the other eye very closely if it's a primary opening of glaucoma just with one eye being affected at this time.
Okay.
Yeah.
Another question, have you seen any patterns or incidents of changes in a patient's glaucoma condition post-vaccination?
Yeah, so that's what I was trying to get at with the stress. No, so we have seen, in general, we have seen now thousands of patients in our office who have gotten vaccinated and have not had a problem with it. I will say that I know the vaccination can cause a temporary kind of Bell's palsy, which is a temporary paralysis of some facial muscles due to a nerve. I have seen one who had a eye muscle, after he got the vaccine, one of his eye muscles didn't work as well. And, but those will recover over time. We have not been seeing a pressure issue, but I will kind of caveat that with people's biology is different. And even with drops, some people will have a side effect that I haven't maybe seen before. So I would definitely say that is not the case, but if it was something where a stressful event happened and the pressure goes up a little bit, transiently it will probably come back down.
Thank you.
Yes, I think we have another question.
Okay, Carrie, go ahead.
Yes. I have congenital glaucoma, which means I had it from birth. And shortly after I was born, I was probably less than a year old, they removed my right eye because of the glaucoma in the hope of saving the left eye. Now, is removing an eye for glaucoma still a common practice or not?
So we usually would remove the eye if it was a blind and painful eye, or if we thought it was at risk for hurting the other eye, which is a disease called sympathetic ophthalmia. It is very rare, usually associated with trauma, but that would be if there was any indication that they were concerned that what sympathetic ophthalmia is, your body actually takes the eye that is already damaged and it recognizes it as foreign almost, and then starts attacking the other eye. So it's kind of an autoimmune disease of the eye, if you will. So if they were at all worried about that, I mean, I guess that could be the reason. I don't know your case in particular. But typically when we're talking about removing an eye, it's because it is not a seeing eye and it is causing you pain, and there's absolutely no reason to go through life with a blind and painful eye when we can get you comfortable. Yeah. Thank you for that question.
I've got another one that someone wrote in. And does glaucoma affect other parts of the eye, like the cornea, retina, or macula?
So glaucoma is an optic nerve disease. The fibers that go in to make up the optic nerve come from the retina. So we often are looking, when we do some of our scans, we're looking at the retina in order to kind of do a thorough evaluation for glaucoma. But really it is an optic nerve disease. We often work with our subspecialty colleagues. It's not uncommon to have multiple different eye conditions, but the glaucoma itself is usually related to the optic nerve. It's not like if you have glaucoma, you're going to get corneal damage or any other layer of the eye.
Thank you. There was another one, are cataracts and glaucoma related?
Oh, that's a good question. No, so they're two separate things, but we do link them together in some instances, and let me explain that. So cataract is the natural lens in your eye, which is located behind the iris, is gradually hardening and getting discolored over time. That's what a cataract is. That happens to everyone. We all get we're all getting cataracts. We've had them taken care of. So that's just a normal aging process. Glaucoma is not a normal aging process, but it is more common as we age to develop glaucoma. But that, again, is the optic nerve issue. So they're two separate conditions. However, there are some instances where we're taking care of both at the same time. I was mentioning there's a lot of new glaucoma surgeries that are available now. Many of them we do in conjunction with cataract surgery. So if you're going to the operating room to get your cataract fixed, wouldn't it be great to try and reduce the number of drops that you needed or help your glaucoma a little bit? Absolutely. So we do a lot of those surgeries in combination together. And sometimes, this is not that common, but sometimes the cataract is causing a problem with the pressure. So if you get a really big lens, remember that's behind the iris, and it's kind of pushing things forward, all of a sudden we can't get that fluid out as well, and we start having pressure issues. So going in and taking out that lens can be a big help. So there are some instances, especially with it's more of a narrow angle situation, that addressing the cataract is very helpful with glaucoma treatment. And just one other thing, just cataract surgery itself can actually help the pressure in some patients. So there are some links, but generally we think of them as two different processes. Good question.
Thank you. Good question.
Sure.
I have crystal lens put in about 12 years ago. Do that cause the glaucoma?
No. No. So Chris,
The pressure.
yeah, no. So putting any lens in, doesn't matter whether it's a crystal lens, a regular lens, a new multifocal lens, toric lens, that doesn't cause the glaucoma. Any sort of eye surgery can have a higher risk of developing glaucoma, but it's very uncommon after cataract surgery.
That cause pressure going up?
No, typically no.
Right now, my doctor cannot bring down pressure.
Bring down your pressure, yeah. It is more common to see glaucoma after corneal surgeries or retina surgeries. Sometimes after cataract surgery, if it was a harder cataract surgery, we can see pressure issues. Sometimes that glaucoma was, maybe you were predisposed to it. Some people, maybe it was in the genes, and it finally kind of starts to come out and manifest. And after cataract surgery, you have to go on steroids to control the inflammation. We talked about steroids. Sometimes we'll start to get some pressure issues with that. But by and large, when we think, like I said, everyone gets cataracts. And so it's not common at all to not have a problem and then develop glaucoma after the cataract surgery alone.
Thank you.
Yeah, good question. Thank you. Yes.
I know there is a lot of kind of surgery for glaucoma. Like they building a new drainage. Mm-hmm. Which one you recommend?
Depends. Really depends on the patient. There are, so the pluses and minuses to everything. So if we're thinking about getting a new drainage system, the traditional surgery that's been done for probably 50 years, trabeculectomy, that uses your own tissue to create a new pathway. So we create this little trapdoor that the fluid goes underneath and it accumulates in this, we call it a bleb, it's a blister underneath your eyelid, then goes back into your body. Very effective when it works. You're always fighting the body's tendency to scar. So if you make an opening, your body wants to scar it over. So you're always fighting the body's natural response there. If you can get it working, get it functional, you can have great pressures for many, 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 many years. You also have to worry about long-term risk of infection with that. So you're always tell everyone to be cognizant if they get a red eye with discharge or pain, start antibiotics immediately, let me know, because it's a little higher risk of infection. There are other types. There's kind of an updated trabeculectomy. It's called a Zen stent, and then we have another one coming out, should be approved by the FDA any day now, really, called a PreserFlow. Same concept, but we're putting a little stent in instead of using your own tissue to make that trap door, but rerouting the fluid there. Tends to be a quicker procedure, a quicker healing time, a little bit more predictable with the results. You still have to fight the scarring. We're still kind of fighting the scarring game with any of our glaucoma surgeries. And then there's the tube shunt, and that's a bigger tube that we put in the eye. That reroutes the fluid to it. It's a plate. A reservoir. so on top of the eye, and then the fluid goes there and then goes back into the body. So we don't have to fight the scarring because we got a tube that stays open there. But you also have a tube in the eye, and sometimes you can have a little swelling around that tube and some little bit of double vision. And so there are other issues with that. Doesn't get the pressure typically as low as what you can get with a trabeculectomy, but not everyone needs a pressure of 10. Some people just need a pressure of 15, and their nerve is going to be okay. So it depends on the person's eye, what their target pressure is, kind of what surgery we might recommend. But it's nice to have options. Yeah.
What do you think the reason of the person he does 3-time laser treatment with close angle and still have a high pressure? What?
So the laser for the closed angle, the narrow angle, they're making the opening in the eye. So what you usually, once you get an opening, it stays open. It usually doesn't scar back.
No, I'm sorry, maybe I didn't know how to explain myself. I'll try again. The person have glaucoma, and he want to get down the pressure. So he has also close angle, and they did 3-time laser for the glaucoma, and it didn't work. What is the reason?
That's very specific case. There's different types of laser, which is why I'm hesitating. We have the laser that I was talking about making the opening. Then we also have the laser that we do to the drainage channel that has to be open in order to do. I have other lasers that I didn't even tell you all about that kind of tries to pull the iris away for certain types. So after we do the initial opening, we pull the iris away. So that's a very specific case, and because we have different lasers, I'm not sure how to answer that in that case. But we have to, again, you have to tailor each individual. If their pressure's still not where it needs to be, we have to go on to something else. And it may be trying to pull that iris away, and maybe something else, maybe drops it, maybe other surgeries at this point if you've done it 3 times. But that sounds like a very specific case.
Another question from
Sure.
a viewer. How likely is a child to inherit the parents' hereditary glaucoma?
Great question. So it's very complex genetics with the primary opening of glaucoma. And it's not like if you get this gene, you're going to get glaucoma. We think it's probably an interaction of genes and probably some environmental factors, some epigenetics at work here. We don't fully understand it. There are a lot of research going into the genetics of glaucoma. Like I mentioned, there's different subtypes. I mean, I kind of give highlights for you, but then we have pseudoexfoliation glaucoma, we have pigmentary glaucoma, we have uveitic glaucoma. There's so many different types of glaucoma, and they're all a little different. So they're not going to have the same genetics. So even if we just look at the primary opening of glaucoma, there's multiple genes that have been identified to play a role. And so we can't really put a number on it to say, Mom has glaucoma, what is my chance of getting the glaucoma? We know it's more likely, but I hesitate to put any percentage on it other than recommending that you need to get eye exams. Yeah.
Thank you.
Good
Another question.
Sure.
How do you treat extremely low pressure, say pressures at 2, 3, 4?
Yeah, those are harder to treat. So what we do, if the pressure, physiologically, your eye has many mechanisms to prevent that. So we don't typically get a low pressure unless we have done something, surgery, typically, to allow that to bypass all of those mechanisms to prevent hypotony. Your eye does not like to have low pressure. So there's a reason, there has to be a reason for it. So either there's something going on with the eye, there's an extra pathway maybe where fluid is getting out that we need to address, there's fluid accumulating in the back that we need to address, or there's something we've done glaucoma-wise to get the pressure down, we've just overshot a little bit and gotten a little bit too low. We usually try, so it depends on the cause of the low pressure. We try conservative things first. Often with time, things do improve. We usually give steroids in this case to help us raise the pressure typically. And then if that still doesn't work and we still have low pressure, we can go in and revise any surgery that was done to try and raise the pressure. The reason we would even attempt to treat low pressure is it can cause blurry vision. Your eye likes to be kind of inflated to a certain amount of pressure, and if it's too low, it starts to get some kind of wrinkles in the back, and if that happens, you just don't see well through it. So we want to try and get the vision restored. That said, there are some people that can tolerate a pressure of 4, even though that's very low, and not have those vision issues. But if it's visually significant, we do try and address it. Yeah.
Thank you.
Mm-hmm.
I've got another online
Sure.
question. If a person has trouble using drops, would you immediately perform surgery?
No, not immediately, not that day. We don't rush them to the operating room. So with drops, I didn't even talk about some of the other drop options. There are preservative-free drops. There's that new implant that I mentioned that is releasing the medication over time. There's compounded drops. So there's a pharmacy that can compound your drops all into one bottle that doesn't have preservatives in it. So we have a new kind of, if you've been into our office recently, there's a new, we call it the nano dropper. It's a little top you put on it, and it makes the drop smaller so it's easier to tolerate. So there are options here. So we explore those options before, hurrying off. We are all surgeons, but we do. We explore everything first, and we really find what's best. There are some patients who are very grateful for going in and getting a stent or something along those lines and not having to use drops. And that is a wonderful gift to be able to give someone. But we don't have to jump there quickly. So.
This one's kind of related. It's how frequently is an implant used to deal with medication allergies versus laser?
Okay. Depends on the implant that they are referring to. If it's the implant where we inject the little pellet, that is medication. So if you have an allergy to that medication, we are not putting that into your eye. Absolutely not. Laser is a great option for people who are having a hard time tolerating medications because it works generally about as well as one drop would. So it can lower the pressure by about 20%. It's successful in most patients for a few years, 2 to 5 years on average. So that's a great option. If the implants they're referring to is surgery, that is an option when you have multiple medication allergies and you're trying to get the pressure, and that is what we would go to sometimes. Putting a stent in may be the way to go.
Okay, thank you. Well, we are about at the end of the time. Does anyone else have a question they'd like to ask? Maybe we can do one more.
Sure.
Thank you for coming, Dr.
Oh, thank you for coming.
Is there a support group for people with glaucoma?
That is a
Did
wonderful
anybody know
question.
of
I do not know of an in-person glaucoma support group. I have a feeling there's probably some online communities. For those with end-stage vision loss, the Lighthouse for the Blind is a resource that I give patients, but what a wonderful thing to think about having is a group of people. And actually, to your point, I actually had someone today ask me, is there anyone that I can talk to? Because it would just be nice to be able to talk to people who have been in similar situations. I think that's a wonderful idea. I'm not aware of any, and perhaps we can start something. The talks? The talks, is that what you're referring to? I believe, Mike, correct me if I'm wrong, this is the third one? Is
Six
4?
total. Our
Okay.
goal was to do them quarterly.
Okay.
So far, we've been tripped up, COVID being the latest thing.
Yeah.
But actually, we're really going to try to stay on track and do one about every 3 months.
Yeah. Yeah, we took a bit of a hiatus there. It's so nice to get to see people in person.
Okay, and so the last thing we're going to do is do a drawing for the 3 gift bags. And we've essentially sorted these into 2 categories, the Zoom audience the in-person audience, and then after those 2 drawings, we'll mix all the tickets together. So
Okay.
Michelle's our official drawer as well.
All right. Let's see. Okay, so we have number, you may call it the number?
Yeah, then
Okay.
you'll just have the number.
415345. 415345.
All right. There you go. Congratulations. Okay, and this is for our Zoom,
We can't afford that.
and these will have a name on them.
Oh, these are names? Okay. James Shoemaker.
Okay,
James
James.
Shoemaker. Congratulations.
Okay, great. Let me just mix these together now.
Okay. This one doesn't have a name, so I guess it's a number.
Oh,
Okay.
that would be an in-person.
Okay. All right, here it goes. 415342. You win? All right.
Congratulations. Well, thank you very much, Michelle. We appreciate everything.
thank
We
you, guys.
appreciate all of you being here.